Buongiorno tutti.
Buongiorno.
Okay, that's the extent of my Italian for now. So it really is a pleasure to be here. Thank you for the invitation, and I love being part of a course with Eddie. We work very well together, so we're looking forward to it. So to begin with, the first presentation is on intraductal epithelial proliferations, and really sort of trying to discuss a diagnostic approach to these entities with a focus on the differential diagnoses, ancillary studies that can help inform diagnosis. So when I think about intraductal proliferative lesions, it's basically this group of entities. So UDH, columnar cell lesions, the atypical hyperplasias, carcinomas in situ, and papillary and benign sclerosing lesions. And these entities all share the fact that their proliferation is contained within the duct. And therefore, they will be positive. They have myoepithelial cells, and the use of immunohistochemistry can be employed to identify those myoepithelial cells if you have difficulty in seeing them. We then can sort of carve out this other pair of entities. Usual ductal hyperplasia and papillary and benign sclerosing lesions share with one another the fact that they are composed of a heterogeneous cell population, and therefore from an immunohistochemical perspective, they will be CK5-6 positive and variably positive with estrogen receptor. And this, as I'll demonstrate, can be used to help in the differential diagnosis of these lesions. So let's begin with usual ductal hyperplasia. The key features of UDH, I'm sure you're all very familiar with. That is that it is composed of a heterogeneous cell population in which the cells vary in size, shape, and orientation. And the cell borders are poorly defined. As well, there's variation in the size, shape, and placement of nuclei with areas of overlapping nuclear grooves and intranuclear inclusions. And then, so those are the cytologic features. You have also architectural features, which the lesion can be solid, it can be fenestrated, in which case it has these sort of holes in it, or micropapillary. When there are these fenestrations, the spaces or lumens are irregular, variable in size and shape, and they're often slit-like and more frequently displaced to the periphery of the space without polarization of the cells around those lumens. And if you have bridges going across the duct, the space, they tend to be sort of more pulled out, stretched, or twisted with central attenuation of the epithelial cells. So here are some illustrations of those features. So what you can see here is an epithelial proliferation. It looks very haphazard and heterogeneous on low and intermediate power. You can see that there are some spaces which are more slit-like, and they're preferentially distributed at the periphery of the involved duct. On higher power, you can see variation in size and shape of the nuclei. You can see some intranuclear inclusions, and again, an absence of any polarization of the epithelial cells around these spaces. And there's a lot of variability in the size and shape of the nuclei. Things become more challenging when you have usual ductal hyperplasia involving an area of sclerosis. There, the stroma starts to change, and so it can be either a little bit more cellular, it can look a little more hyalinized or fibrotic, and you can get distortion of the ducts, which might make you think about an invasive process or DCIS because of the sort of more complicated look. And I think people can get unnerved by the appearance, but I think what you should do is sort of go back to those key features that we just talked about, see that the spaces are preferentially located at the periphery, they're slit-like, there's variability in the size and shape of the nuclei, we have intranuclear inclusions, we have some nuclear grooves here and here, and there's really no indication that this is an atypical epithelial proliferation, and so therefore you can determine that it is usual ductal hyperplasia. If you need to use adjunctive immunostains, as I mentioned, usual ductal hyperplasia has a mixed population of cells, and they express, that population may express low and high molecular weight keratins. And the latter is the one that we use in our department often is expressed in a heterogeneous or mosaic pattern. In contrast, DCIS is composed of a monoclonal population of cells that express low but not high molecular weight keratins. And so this can be used to help distinguish atypical from non-atypical proliferations. So here on the right are the pair of stains that we use. We use CK56 and ER separately, and you can see that there's heterogeneous expression with CK56 and variable expression with ER within the usual ductal hyperplasia. Some of you may use some form of ADH5 or the triple stain, which includes a low and a high molecular weight keratin. Here, the low in red cytoplasmic, the high in brown cytoplasmic, and as well, it includes P63 to highlight the myoepithelial cell layer. Then just to sort of put in words, mixed population of cells with heterogeneous expression of ER, as I just illustrated, is what you'll see in usual ductal hyperplasia. And then in DCIS, at least for low and intermediate grade DCIS, you'll have strong and diffuse expression of ER. Exceptions being, of course, high grade DCIS, which can be ER negative, or apicrine DCIS, which can also be ER negative. But those will be much more easily recognizable and not really enter into the differential diagnosis with usual ductal hyperplasia. So here, just on higher power, ER staining in usual ductal hyperplasia, where you'll have some darkly stained nuclei, but you'll also have some weakly stained nuclei and some negative nuclei. And this is very typical of usual ductal hyperplasia. So in the distinction of these two entities, points to consider, I think really the differential diagnosis is most often with intermediate nuclear grade DCIS. Really, UDH is not confused or should not be confused with atypical ductal hyperplasia or low grade DCIS, because that's composed of very round, regular monomorphic nuclei that don't look anything like UDH. It's really intermediate nuclear grade DCIS. And I think that's quite difficult myself. And so you can use immunostains in that situation. Micropapillary patterns can also sometimes be a bit of a challenge, and I'll illustrate that shortly. And then I think also think about the imaging target. DCIS is more often an imaging target, right? It's associated with calcifications, at least the low-grade type more often. Intermediate-grade DCIS can be architectural distortion or a non-mass enhancing lesion. UDH is less often a mammographically detected lesion. It can be an MRI detected lesion, but that might influence, help with interpretation. And then, as I've already illustrated, using immunohistochemistry in problematic cases can help with the differential. So here's just another illustration of a tricky case where you've got what looks like some variability. And the other thing actually to say about intermediate grade DCIS is you don't always have that nice polarization around the spaces. And so that is not necessarily so helpful. So here's a sort of case where I think the differential diagnosis might include usual ductal hyperplasia. It looks like we've got streaming of the nuclei. We don't really have any punched out spaces with polarization, which, as I said, you don't always get in intermediate grade nuclear grade DCIS. One of the features that I rely on for that distinction, at least on H&E, is I feel like the nuclear chromatin looks very similar one cell to the next in intermediate grade DCIS. And that's sort of something that I use. Here, of course, we do have some invasive carcinoma, so that's a bit of a clue as well. But that, that can be the sort of challenge that I think we're faced with. And then involvement of benign sclerosing lesions can also, as I mentioned, lead to misinterpretation as DCIS or invasive carcinoma. Sorry, the slide is misformed here. The presence of necrosis can lead to misinterpretation as DCIS. And I think what you need to do in that situation is sort of imagine the proliferation without the necrosis. So sort of mentally subtract the necrosis from the proliferation and then decide, are the features those of usual ductal hyperplasia or DCIS? And then getting back to benign sclerosing lesions, decide whether the stroma is pink and fibrotic, And in that situation, I sort of start from a place of benign and then work my way out of that. And also use myoepithelial cell markers in that situation, but interpret with caution. And then a heterogeneous expression of ER can be a useful safety check. So here's a really nice example that illustrates many of those points. So we have a core needle biopsy here. There are some irregularly shaped nests with an epithelial proliferation within. The stroma is a little bit pink and fibrotic, I would say. And so one might be thinking about DCIS or invasive carcinoma here, but I would point to pink fibrotic stroma as being something that should indicate the possibility of a benign sclerosing lesion and start there, and then, rule that in or out. On higher power, stroma starts to look a little cellular in some places. So again, you might start thinking about desmoplasia, but be careful. I actually can see a myoepithelial cell layer. So to my mind, I think this looks like some sort of process that is within a duct, be it DCIS or usual ductal hyperplasia. It does look like there's a little bit of necrosis here as well. But as you start to look at the epithelial proliferation, I think there's a lot of heterogeneity here. There are some small nuclei, some larger nuclei. The spaces are slit-like, and it doesn't really look like there's any polarization, which of course is not so helpful in intermediate grade DCIS, but something to think about. And I think it does try to polarize, even though it doesn't do it very effectively. So this case, the original pathologist did actually perform myoepithelial cell markers, here the P63, but interpreted it as some absence of expression. You have to be careful with sclerosing lesions because there can be loss of expression, but also you have to be careful with P63 because the nuclei may not be in the plane of section. And so just where you have some apparent absence of expression does not mean an absence of myoepithelial cells. So the real clue should have been the ER stain. So this case was called invasive ductal carcinoma grade 2. We received it for the patient coming in for treatment. And this ER expression would be abnormal for, unusual, I should say, not abnormal, unusual for grade 2 invasive ductal carcinoma. And so that was kind of really the clue that heterogeneous expression would not go along with that. You'd expect strong diffuse expression in the vast majority of cases. So, I think when UDH involves a benign sclerosing lesion, invasive carcinoma or DCIS is obviously in the differential diagnosis. But as I said, look for those myoepithelial cells, be careful about the stroma, and use immunostains as well if necessary. Sometimes solid papillary carcinoma can be a differential diagnostic consideration for usual ductal hyperplasia. Again, because you've got these rounded nests, you've got streaming of the nuclei, more ovoid shaped nuclei. I think that can raise the differential diagnostic consideration, and the fibrovascular cause, as I'm sure Eddie will talk about, can be very subtle. And so that can be something that's problematic. Here's another challenging case. This was actually called atypical by the original pathologist, sent for a second opinion. That pathologist called it usual ductal hyperplasia, and we received it for a third opinion. And, I think this one's tricky. It looks like maybe there's some rounding of the spaces, but there's not perfect polarization around the spaces. The nuclei look a little bit variable maybe. But since it was a third opinion, we did some immunostains. And so here is the CK56, which shows an absence of expression around the, within the proliferation, but is highlighting the myoepithelial cells. I think actually what's most helpful, almost morphologically at least, or at least what's more helpful morphologically, is that on the deeper sections, the spaces do become very round and there's some cribber forming there. So, so actually this is atypical and not a non-atypical proliferation. Another example of this differential diagnosis of intermediate grade DCIS and usual ductal hyperplasia, where you have streaming of the nuclei, they're more ovoid, the spaces aren't perfectly round, maybe some of them are a little bit slit-like. And so here is this differential diagnostic dilemma. For me, as I said, if the nuclei look sort of, the chromatin pattern looks the same one to another, that's a cue that I might be dealing with DCIS. As well, if I see some apoptosis, that cues me into the possibility of DCIS. The nuclei are kind of trying to polarize. So even though this would be an intermediate grade DCIS, I think the nuclei try to organize themselves. So another example of where CK56 and ER might be useful. And indeed, this shows it's a little bit of a dirty stain, but an absence of expression within the epithelial cells with CK56 and strong diffuse expression with ER. So this is an example of DCIS. And here, just a comparison view of a papilloma with usual ductal hyperplasia and a solid papillary carcinoma where, at least on these sort of low POWs, and again, as I said, Eddie will talk about this in more detail later on, there can be some mimicry of usual ductal hyperplasia if you don't appreciate the fibrovascular cause in these subtle proliferations. So there is management impact from mistakes here, of course. For usual ductal hyperplasia, the patient usually doesn't require any further management. If you diagnose that on core needle biopsy or excision, no further management required. If you call it DCIS or invasive carcinoma, obviously that patient is going to have an excision, mastectomy, or even bilateral mastectomy, which is becoming increasingly the selected option by patients, at least in the US, quite for DCIS and invasive carcinomas to reduce contralateral risk. Moving now to the other side of my little diagram here, what do these entities have in common? And what they share is that they're composed of a monoclonal, shall I move this down? I'll move it down here. A monoclonal cell population, in which case the CK56 would be negative and the ER strongly and diffusely positive. Exceptions, as I already mentioned, would include high-grade DCIS and lesions with apocrine differentiation in which ER could be negative. So columnar cell lesions without atypia. Columnar cell lesions without atypia include columnar cell change and columnar cell hyperplasia. And this class of lesions is characterized by variable distension of the terminal duct lobular units, columnar epithelial cells which line those units, and these cells often have apical snouts, and there are often secretions and microcalcifications in the lumens, and this is how these lesions are detected. They're picked up on mammographic screening due to the presence of the calcifications. You can sometimes see stratification of the lining cells in columnar cell hyperplasia. So here's a nice illustration of columnar cell change in which you see variable dilatation of the acini. So some are larger, some are smaller. You can often see irregular contours as well in columnar cell change and columnar cell hyperplasia, which can be a helpful clue too. Here you see that the epithelial cells are columnar, arranged perpendicular to the basement membrane. Here's an example where it's more reasonable to call this columnar cell hyperplasia. We see the secretions and calcifications in the lumens. You see the columnar epithelial cells. There's a little bit of stratification and mounding up of those columnar cells, but no true micropapillary formation. Flat epithelial atypia differs from the other two entities in the way that they have a monotonous proliferation of cuboidal to columnar epithelial cells. And I would say that the feature that I find very helpful is the acini become very rigid. They have that sort of architecture, even though flat epithelial atypia has no architecture. The acini and the lining epithelial cells seem still to try and have architecture in the way that ADH and low-grade DCIS has, and I'll illustrate that for you shortly. There is low-grade cytologic atypia. The nuclei tend to be round rather than elongated, and you have loss of polarization with respect to the basement membrane, but obviously a flat growth pattern such that the features do not fulfill the combined architectural and cytologic criteria for a diagnosis of ADH or DCIS. So they do have the cytologic features of ADH and DCIS, but not the architectural features. And here are some illustrations of FEA. And do you see what I mean by this sort of rigidity of the spaces? They seem to sort of be trying to do an ADH type of thing, but without the bridges and arcades. And you go on high power and the nuclei look very similar to what you would see in low-grade DCIS or atypical ductal hyperplasia. And we have these secretions and the epithelial apical snouts as well. Here's another terminal duct lobular unit where you again see variable dilatation of the acini lined by this monomorphic population of epithelial cells. And I would say for the young people here, you know, really FEA, I think you should be able to diagnose on low power. If you're going on high power and saying, oh, is it FEA, not FEA, I think really take a step back and fall on the side of columnar cell change. Really the hyperchromasia, the monomorphism, the rigidity should be recognizable at low power, and then you confirm on high power that you have this cytologic monotony that you would see in low-grade DCIS. The differential diagnosis includes microcysts, where you would have a very attenuated epithelial lining and the nuclei would be very small. Apical metaplasia is similar because the nuclei are very round and regular, like in FEA, but you have much more abundant eosinophilic granular cytoplasm. Columnar cell change and hyperplasia are in the differential because of the variable dilatation of the acini, but the nuclei don't look atypical, they're more elongated, and as I say, unless you have those features of low-grade DCIS cytologically, you should fall towards columnar cell change. And then clinging carcinoma or high-grade DCIS with a flat pattern, you know, it's flat and it's atypical and it's epithelial, but it's not FEA. And that should be readily recognizable because the nuclei are far too atypical for a diagnosis of FEA, which, as I said, should have low-grade atypia. So as I alluded to, we're seeing these increasingly in an era of routine mammographic screening due to their association with microcalcifications. And it's important on core needle biopsy, at least in the US, although that's evolving, I would say, to separate columnar cell change and columnar cell hyperplasia from flat epithelial atypia, because some FEA will be excised, not all. I think in many cases where we've moved to an observational stage, but it depends on the extent of calcification. So there, you know, from a molecular perspective, there is evidence to suggest that columnar cell lesions are a non-obligate precursor on the low-grade breast neoplasia pathway, but the sort of epidemiologic evidence is lacking. We see very low risk of progression to invasive carcinomas. And in fact, subsequent carcinomas are of all grades rather than just low-grade lesions, which, you know, may be a function of that long time interval and just sort of other carcinomas popping up in the interval. And so FEA certainly should not be managed as a high-risk lesion in the same way that ADH and lobular carcinoma in situ are managed, but biologically it has the same alterations as we see in ADH and in atypical ductal hyperplasia. The other thing to think about is, or to know and be aware of, is that we often see this constellation of flat epithelial atypia, LCIS and ALH, or lobular neoplasia, in association with tubular carcinomas, sort of lending credence to this non-obligate precursor relationship with low-grade invasive carcinomas. And in fact, this triad is referred to as the Rosen triad in tribute to Dr. Rosen, who first called it out in 1999. So these are not usually a diagnostic dilemma. As I already have emphasized, don't overcall FEA. It's usually recognizable at low power. But really one of the key things about FEA is to look for other more important lesions with which it is often associated. So LCIS, ADH, low-grade DCIS, look for those other things, microinvasive carcinomas, because we have a better handle on how to manage those lesions. And of course they can be clinically important. So our atypical hyperplasias include ALH and ADH, so atypical lobular hyperplasia and atypical ductal hyperplasia. Let's begin with the key features of ADH. Cytologically, it's composed of an atypical cell population, similar to that seen in low-grade DCIS. So small uniform cells with well-defined borders and generally rounded, evenly spaced nuclei. Architecturally, you'll see rigid bridges, arcades of uniform thickness, so no attenuation in the bridges, micropapillations with bulbous tips, and a cribriform pattern with polarization of the cells around those lumens. You can also have a solid pattern as well in small acini. And then part of the definitional criteria are size and extent criteria. So you can have partial involvement of spaces by this atypical proliferation, so sort of a combination of ADH and maybe UDH or a little bit of FEA. If there's only partial involvement, you would call it atypical ductal hyperplasia. Or you can have complete involvement, but of limited extent, so fewer than 2 spaces or less than or equal to 2 millimeters in extent. If it were greater than that, you would call it low-grade DCIS. Less than that, you call it atypical ductal hyperplasia. So here we have some examples of ADH where you see that you've got some cribriforming, you've got some bridges, and these bridges are very rigid. You can see that the width of the bridge is the same all the way across the space. Maybe a little attenuation over in this part here, but that sort of speaks to the definitional criteria of qualitatively incomplete involvement. Another example of incomplete involvement. So here we have our atypical population on the right with polarization around some of these spaces here. Very nicely, it's a monomorphic population. And then over here on the left, really, this is more like columnar cell change, so incomplete involvement. So the differential diagnosis, of course, is low-grade DCIS. UDH, I already talked about that as not being exactly a differential diagnosis, but I think micropapillary UDH and ADH can be part of that sort of differential diagnosis. And then collagenous spherulosis. So here's that sort of differential diagnostic dilemma where you have what looks like a micropapillary proliferation. And is it atypical or not atypical? And when you have a broad base and kind of a pinched tip and larger nuclei at the base and smaller nuclei at the tip, then you would lean towards a diagnosis of usual ductal hyperplasia, gynecomastoid pattern. Micropapillary atypical ductal hyperplasia, and obviously this is a really exaggerated example to illustrate the point, has these sort of light bulb shaped or bulbous micropapillations in which there's a narrow base, bulbous tip, and the nuclei should be monomorphic and atypical throughout the proliferation. So this is sort of a compare and contrast of those two. Collagenous spherulosis can be a pitfall. That can be a mimic for ADH and low-grade DCIS, but look for the myoepithelial cell nuclei that are not polarized, but rather running parallel to the spaces and the basement membrane material. And then, and Eddie might talk a little bit more about that later on as well. So here's a fibroepithelial lesion, might not be able to recognize that so easily at this intermediate power, with some gynecomastoid hyperplasia, some micropapillary type hyperplasia. But in one of the spaces, very limited in extent, we have a monomorphic population of atypical epithelial cells with polarization around these spaces. So an example of atypical ductal hyperplasia here. Here we have a similar type population, monomorphic epithelial cells, but obviously much greater in extent here, and so easily diagnosable as low-grade DCIS. So ADH versus low-grade DCIS criteria, it's important to remember that the criteria were developed in excisional biopsies. And so the thresholds that we set for this are a little bit arbitrary, but they're agreed upon. So by convention, we've decided what they are. But important to remember that the WHO Classification of Tumors Editorial Board recommends a conservative approach when lesions are of limited extent, when lesions of limited extent are identified, especially in the setting of core needle biopsies, in which the entire lesion may not have been visualized. And so you don't know that when you have a core needle biopsy, whether you have the whole lesion or you don't have the whole lesion. So circumspection and a conservative approach is advised, and a wait for definitive categorization on excision. Now, it may be a little different in Europe because maybe you're not excising all atypical ductal hyperplasias. In the US, still in the vast majority of institutions, if the patient's not on a clinical trial, we are excising atypical ductal hyperplasia. So again, we fall on the side of ADH on these lesions that are on the threshold because there could be an excision, a cancer surgery if we don't do that. And I think, important to recognize that ADH falls on the spectrum there's this spectrum from FEA through to low-grade DCIS, and often you have a lot of everything going on, right? You have FEA, you have ADH, you have low-grade DCIS, and you sort of have to decide where is what and what is where and how to agree. And we know that their disagreement rates for ADH well, I suppose the disagreement rates are high, but the agreement rates are low, of about 40 to 60% compared with lesions at either end of the diagnostic spectrum, in which we have very good agreement, greater than 90%. And it's also been demonstrated that variability in diagnoses are related to differences in professional opinion and diagnostic threshold practices. Second opinions and consensus conferences can improve agreement. It's also stated that IHC can improve diagnostic agreement. I think that's a little bit debatable. IHC is not going to help with the differential of FEA, ADH, and low-grade DCIS. They're all going to be CK5-6 negative and strongly in diffuse CER positive. So it's not going to help with that. It may help with the micropapillary UDH versus ADH or DCIS. So our sort of mantra really is that the diagnosis of ADH should not be made unless you're actually seriously considering whether or not it's low-grade DCIS. So you shouldn't be sort of thinking, oh, is it atypical, not atypical? You should be thinking, gosh, could this be low-grade DCIS? But really there's not enough of it. And that should be where your threshold is. And I think also on a core needle biopsy, you shouldn't be diagnosing low-grade DCIS unless it's absolutely unequivocal, that everybody you show it to is going to agree that it's low-grade DCIS. In the US, as I've already mentioned, patients are increasingly opting for mastectomy or even bilateral mastectomies as a therapeutic strategy, surgical strategy following core needle biopsy diagnosis. So if you have a lesion of limited extent and low cytologic atypia, patients may end up with bilateral mastectomies and you may have nothing more. So what we advise is a diagnosis of atypical intraductal proliferative lesion. You could say bordering on DCIS, that is sufficient to prompt surgical excision. And then your definitive categorization can be based on evaluation of the excision specimen. And if there's no further lesion, the patient could be managed as atypical ductal hyperplasia. So here's some borderline lesions. We have two spaces here. So, by rights, by definition, one could call it low-grade DCIS, but it's so tiny, so limited that I would call this atypical ductal hyperplasia. Here, multiple spaces, but very limited in extent. Again, a diagnosis of atypical ductal hyperplasia is more appropriate. So the WHO has this guide to evaluation. They start with cytology. If you've got low-grade monotony, then you're going through this algorithm. Then you do the architecture. If you have rigid bridges, arcades, all these features that I've already pointed out, then you evaluate extent. And if it's either non-uniform involvement of spaces or uniform involvement, but less than or equal to 2 millimeters, then your diagnosis is atypical ductal hyperplasia. And I already talked about the management impact. So now moving to carcinomas in situ, and here we're talking about LCIS and DCIS, and obviously I'll focus on DCIS because Eddie will be talking about lobular lesions at a later time. So DCIS is classified according to nuclear grade, and either as low grade or high grade, and the large pleomorphic nuclei for the high grade, or something in the middle, which is our intermediate nuclear grade. And then we also classify based on architectural pattern and presence, or we also document, I guess we don't really classify it so much, but document the architectural pattern, the presence or absence of necrosis, whether it's comedo necrosis or focal necrosis. And this distinction is not that well defined either. So we can have cribriform, we can have papillary, we can have micropapillary, and solid patterns of DCIS. And here just another nice example of DCIS. We've got multiple spaces involved. It's quite extensive. You can see that it's a monomorphic population with polarization of the epithelial cells around spaces that are round, regular, and fairly evenly distributed throughout the duct. You know, it's never perfect, right? Some of the spaces are more slit-like, but a majority are round and evenly distributed. So our differential diagnosis of DCIS, we've already talked about some of these things. The collagenous spherulosis, especially if it's involved by LCIS, becomes a differential diagnostic consideration. LCIS, especially solid pattern, and our florid and pleomorphic variants are a differential. Microinvasion is not really a differential diagnosis of DCIS so much as something that you might overlook. And then there are some invasive patterns of carcinoma that can be a mimic for DCIS, such as adenoid cystic carcinoma, invasive cribriform carcinomas, or even some of our solid papillary carcinomas. And then LVI can also be a mimic. So here, just a little picture for the handouts, really showing you LCIS and collagenous spherulosis that can be a mimic. And again, as I said, I'll let Eddie focus on that tomorrow. So features of DCIS associated with microinvasion: high-grade comedohistology should be a cue to start searching for microinvasion, but it's important to remember that microinvasion can also be seen with other grades and types of DCIS, as well as with LCIS. So just, you know, it's important to bear that in mind. If it's very extensive DCIS, that's another clue that you should be looking very carefully for microinvasion. And of course, if there are these periductal lymphoid infiltrates, everybody's Friday afternoon nightmare, that's the other time that you want to be looking very carefully. And this is that case, right, where you know that there must be microinvasion somewhere, but where is it? So this is high-grade DCIS. It's extensively involving the resection specimen that you have. You've got periductal lymphoid infiltrates. And so, you know, my approach is really sort of a low power look to see, you know, where are there areas that might look a little different and where are there larger cells within this inflammation, and to try and pick out this, these foci of microinvasion. Myoepithelial cell markers really are challenging unless you've got an area of microinvasion that you're looking at, because just using a plain old myoepithelial cell marker is not going to help. You need to either use it in combination with a keratin or have an area in question that you're going to do your immunostains on. So here are areas of microinvasion within this case of extensive DCIS. So what are the challenges? Well, overdiagnosis, there are situations in which DCIS might have areas that mimic invasion, such as duct branching, or involvement of lobules can be a mimic for invasion. I talked about involvement of benign sclerosing lesions, but adenosis can be a mimic of invasion, distortion of involved spaces, tangential sectioning, and then there are various artifacts that can mimic invasion as well. And also, I think less an issue nowadays, but sort of the practice of defensive pathology of saying, you know, suspicious for microinvasion. I always say, unless you can actually dot it with your dotting pen, you shouldn't say it's suspicious for microinvasion. So here's just an example of some epithelial displacement, but through manipulation of the tissue. These cells have been displaced out of this micropapillary DCIS along with necrosis. This is not microinvasion, this is artifact. It's not always possible on H&E sections, even with multiple levels, to be confident about the distinction between invasion and invasion and DCIS. So it can be helpful to use myoepithelial stains if you have an area in question. And so here's an example of one of these mimics where you have DCIS possibly involving adenosis, but possibly it's an area of invasive carcinoma. We obviously have DCIS here on the left, but what are these small glands and nests? Are they invasive carcinoma or are they adenosis? And, you know, the advice, of course, is to look on low power and look for lobular centricity, but that can be difficult. And, you know, so sometimes we do need to use myoepithelial cell stains. And here a smooth muscle myosin heavy chain highlighting that myoepithelial cell layer. allowing us to be confident that it's DCIS in adenosis. And then, as I said, there can be underdiagnosis or misdiagnosis because you overlook the focus of microinvasion, or it may simply not have been sampled, right? If you have this mastectomy that was performed for 6 centimeters of microcalcifications, and you've put through many sections and you've got extensive DCIS, it's very likely, or it's very possible, I should say, that there could be a focus of microinvasion that just hasn't been sampled. Other mimics of DCIS, invasive cribriform carcinoma can be a mimic, solid papillary carcinoma, adenoid cystic carcinoma, and LVI. These all have these rounded, nested growth patterns. Invasive cribriform carcinoma has more irregularness and infiltrative growth pattern. That's what you should rely on. But sometimes it can be difficult to decide how much is DCIS, how much is invasion. So immunostains can be helpful for myoepithelial cell markers, can be helpful in this situation. Also helpful deciding on the extent of the invasive component. So they're just to sort of summarize in words the mimics of DCIS. And here, just an I'll show you the immunostain for this example of invasive cribriform carcinoma, where, I think on H&E, you can be fairly confident that these epithelial cells are directly abutting the stroma and that there is no myoepithelial cell layer. But sometimes it can be difficult to decide if these myofibroblasts are attenuated myoepithelial cells or not. So immunostains sometimes will be good in resolving that challenge. And I already illustrated this point about DCIS in a pre-existing lesion mimicking IDC, especially on a core needle biopsy where you don't always have that kind of low power view to help. And then just a sort of word of caution, and I alluded to this at the very beginning when I showed you that case of misdiagnosed UDH in a sclerosing lesion. Myoepithelial cell markers can show reduced sensitivity for DCIS-associated myoepithelial cells when compared to their sensitivity for normal myoepithelial cells. And we and others have showed in several studies now that there are phenotypic alterations in the expression pattern, especially with smooth muscle myosin heavy chain, but some have also shown it with P63 and CK14. So that means that you have to be careful in your interpretation, use a panel of immunostains to be sure that you have appropriately excluded the possibility of an in situ proliferation. And here, the final mimic of DCIS. This is extensive lymphovascular space invasion, and this is really tricky, right? So it looks exactly like DCIS, rounded nests, comedonecrosis, some cribriform spaces. The clue here is to look for these normal terminal duct lobular units kind of interspersed in between. And that's sort of not really a normal pattern for DCIS. It doesn't typically skip areas. And so if you see things like that, you should consider the possibility that you might be dealing with extensive lymphovascular space invasion. And then you can do your immunostains, D240, but do remember that that cross-reacts with myoepithelial cells. So I always pair it with P63 or smooth muscle myosin heavy chain, some other myoepithelial cell marker, to be sure that if that is staining as well as the D240, then I'm dealing with DCIS. If the myoepithelial cell marker is negative, the D240 is positive, then I'm dealing with LVI. And I guess if they're both negative, then I'm dealing with invasion. So it can be very, very tricky. Ooh. All right, I think I might have a little bit of a hitch here. So hang on, let me just. Oh yeah, so sorry. This is our management final slide here. Yeah, so this is just the management, putting it all together in a final sort of diagram. So at least bearing in mind in the US now, this sort of cut point here is really that radiologic pathologic correlation is key, and we're evolving to no surgery if there's rad-path correlation and no ductal atypia. Then these patients can go on to either back to routine screening or maybe short interval follow-up and then routine screening. Exceptions are, of course, atypical ductal hyperplasia and DCIS, and those patients will go on to excision. So to summarize, UDH columnar cell lesions, no further treatment if diagnosed on no further treatment. Evolving for flat epithelial atypia, but moving towards no excision if there's good rad-path correlation. Benign sclerosing lesions and papillomas, and Eddie will elaborate on this, I'm sure. Evolving for complex sclerosing lesions, but beginning to move toward no excision if there's good rad-path correlation. We do excision for symptomatic papillomas, no excision for incidental or small asymptomatic papillomas. ALH and classic LCIS, again, this will be discussed more tomorrow. Excision not required for incidental rad-path concordant lesions. ADH, excision is the current standard of care in the US. Not necessarily so in Europe, I think, but you can educate me on that. And then difference in management algorithms has resulted in different diagnostic thresholds in our practices, I think. And then the other thing is that paradoxically, there are trials for active surveillance of DCIS, but ADH is still currently being excised when diagnosed on core needle biopsy. So again, trying to be very consistent in our diagnosis patterns. The current standard of care is excision, although, as I mentioned, active surveillance for clinical trials are in progress. Interestingly, I'm told that enrollment has been a bit of a challenge due to women wishing to opt for the observation arm once learning of the risks and not willing to be randomized to surgery. And so some of the trials have a non-randomized arm that patients who don't wish to have surgery are being followed. Obviously not truly part of the trial, but creating that pathway to observe patients. So for excision specimens, no further treatment for the benign lesions, observation and offering chemoprevention for ADH and lobular neoplasia. DCIS requires complete local eradication with clear margins, chemoprevention, and as I said, there are new trials. So just final word on subsequent breast cancer risk for these benign intraductal proliferations. There's a 1.5 to 2-fold increase in subsequent breast cancer risk, so very modest. For atypias, 3 to 5-fold increase in subsequent breast cancer risk, so those do constitute high-risk lesions. And then for our carcinomas in situ, an 8 to 10-fold increase in subsequent breast cancer risk. So to summarize, I've discussed the histologic features and differential diagnosis, as well as diagnostic difficulties associated with these intraductal proliferative lesions. We've looked at distinguishing the IHC, the different distinguishing immunohistochemical panels for these difficult ductal proliferations, and discussed the current management strategies. So with that, I will close and we can have a discussion.